We're so fortunate to have a repeat speaker with Dr. Benditt, Professor of Pulmonary and Critical Care Medicine at the University of Washington in Seattle. We all enjoyed his talk last year. He spent his life working with patients with neuromuscular disease and breathing issues for the past 25 years, and he devotes most of his outpatient practice to caring for these individuals. He also helps us respiratory therapists frequently. He's a Northwest native and loves to work in his clay studio. I've actually seen some of his work on display. He's quite the potter. So thank you, Dr. Benditt.
Great. Great. Thank you, Angela and ResMed and the Salk Institute for having me down here again. It's always fun to come here. And the reason is because right now, in Washington, it's raining wildly, and the salmon are trying to cross the road. We have a lot of coffee in Seattle to try to help us through the winter. It's raining and about probably 48 degrees there, so thank you for having me. Dr. Hahn, thank you for the lovely talk. That was very interesting. I look forward to talking more with you. What I'm going to speak about today, Angela's asked me to go over kind of a broad area. And there's a lot of information and a lot of medical stuff here. I'm going to try to be as clear as I can with it. If after the talk there are specific questions, we can go over that. But Angela's asked me to talk a little bit about the anatomy and physiology of the breathing system, and then talk about different diseases, not only post-polio, but other neurologic diseases that can cause problems. Then how do we approach these issues, and then a little bit on sleep and neuromuscular disease, and you've heard a little bit about that already from Dr. Hahn. It's a very old area of investigation. In fact, an Alexandrian physician named Eratosthenes postulated that the diaphragm was the main generator of breathing, which was a correct anatomic description, and that was in around 280 BC. And then Galen, who was a Roman physician, noticed that warriors who were injured below the neck in fighting continued to have breathing, but if there was an injury at the neck level or higher, there was no breathing, and really realizing that the nerves from the neck allowed breathing. It was Da Vinci in 1508 who delineated the anatomy of the diaphragm. This is one of his drawings, and the phrenic nerve that comes down from the spinal cord. So it was that long ago that we knew how the breathing muscles and nerves worked, and really over the next, 300 years, the entire system was put together, and I call this the respiratory pump, and you'll see it referred to in the medical literature. But it includes the muscles, the activating force generators that are the diaphragm, but also the chest wall muscles, but also the nerves that go to those, the motor nerves here, the nerves in the spinal cord, but also the brain stem, the medulla and the pons, and the motor cortex, which for voluntary breathing is necessary. For instance, for me to be able to control my breath up here, I need the cortical input. There are also feedback loops to the controllers here, and there are chemical receptors in the blood vessels, as well as nerve and stretch receptors in the muscles that allow us to sense how our breathing is going. Now, the central control of respiration to me is really interesting. This is the brain stem, that central part of the brain at the top of the spinal cord, and this is the pons here and the medulla here, and automatic breathing. So when we fall asleep at night, automatic breathing is maintained through 4 different centers that are found in the brain stem that allow us, even though we are asleep and unconscious, to continue to breathe. But during the day, when you're awake and you get scared, or you need to talk, or you need to sing and control the breath, there are cortical centers on the brain, the surface of the cortex, that function both during inspiration but also during exhalation, and this is where we control speech, which is so important to the human existence. This is functional MRI mapping, that is MRI that's occurring during the breathing cycle in humans. Now, there are diseases that can actually affect the control of breathing centrally. So there are things that can affect the cortex and that voluntary control of breathing. There's something called the locked-in syndrome, which is very unfortunate, but where there are strokes, head injury, sometimes tumors, even Parkinson's disease can cause problems with the voluntary breathing, which is why people with Parkinson's may feel short of breath with exertion. There are also disorders of automatic breathing, that medullary center for breathing. One of the kind of classic ones called Ondine's curse is a disease of children where when they fall asleep and they do not have the cortical input to breathing, they actually stop breathing and often need tracheostomy and ventilatory support. We now know that there's a gene that actually gives rise to that. But other things can do that, and in fact, polio, if it was very high up in the brainstem, fortunately that was a minority of patients, but that can affect the automatic control of breathing, so that some polio survivors have great difficulty during sleep, not only due to nerve and muscle weakness, but also due to medullary control of breathing. I'm going to skip through that slide. I want to move quickly so we can kind of catch up with our schedule. But the spinal cord is also obviously a critical area for the breathing muscles, right? Because all of the input from the brainstem and the cortex comes down through the spinal cord and exits through the motor nerves. And a very big problem in the United States and worldwide is spinal cord injury. There are about 11,000 new cases per year in the U.S. The prevalence, or the number of cases total, currently is about 250,000. And breathing is a huge issue because for spinal cord injury, with high spinal cord injury, you are going to be ventilator dependent in some way. The most famous person, I would say, would be Christopher Reeves, who had that. He had a C2 injury. He was ventilator dependent, but he did a lot of things to try to become ventilator independent later on. If it's a lower spinal cord, cervical cord injury, they're almost ventilator independent unless they have other diseases like COPD or fibrotic lung disease. So where the injury occurs in the cervical spine is crucial to the breathing issues. There are many, many diseases that can affect the motor nerves. So as they leave from the spinal cord, or actually in the spinal cord, and the neuromuscular junctions, so where the nerve rootlets, which are shown here. Here's a nerve. This is a beautiful kind of a micrograph, but this is a nerve, and I think it is the phrenic nerve, and it is inserting on the muscle fibrils there, and these little dark spots there are the neuromuscular junction where the transmitters actually stimulate the muscle to contract. In polio, what happens with these motor nerves is that there's degeneration during the acute infection, and then slowly over time the nerves grow back, but they're not quite as strong. And what we think post-polio syndrome is that over time as we age, the nerve rootlets, so-called, start to degenerate, and we get symptoms in the same muscle groups where we had polio. This is the phrenic nerve here, and the brave surgeon is kind of dissecting right along the phrenic nerve. But there are lots of diseases. In my clinic, my outpatient clinic, I have many post-polio patients, but I also have ALS. I have something called spinal muscular atrophy. I obviously have polio. But I also have a lot of other neuropathies. So Guillain-Barré syndrome. I see people who come out of the intensive care unit who have a lot of neuropathy, and then diabetes, et cetera, et cetera. There are a number of diseases that actually happen right here at this neuromuscular junction. So myasthenia gravis is probably the most well-known ones. But once or twice a year, we have somebody in the hospital with botulism. And we had one last month from somebody who ate some bad home canned goods, unfortunately. And we treated him through the acute phase, and then it's taken, or will take him, probably 6 months to recover. Now, in polio, obviously there is an infection. It affects motor nerves that can be peripheral, but also can be in the spinal cord as high up as the brain stem. But there are other problems that occur in patients with polio because of the weakness of muscles surrounding the spine, the paraspinous muscles. So if you're a child and you get polio and you get weakness of the paraspinous muscles and then you're growing, those muscles do not support the spine and you get scoliosis. And some of the most severe cases of scoliosis I've ever seen are in post-polio patients. This has an extra effect on breathing in that it makes the rib cage very rigid, very stiff. And so the weak muscles have a great problem expanding a stiff rib cage. So not only nerve problems, weak muscles, but also rib cage stiffness. Lastly, the kind of final, operator in the chain is the respiratory muscles. This is a diagram kind of from the side of a person showing inspiratory muscles, which is the diaphragm right here. But there are also intercostal muscles, and the external intercostal muscles of the chest help us during inspiration. Also, if you're exercising, your neck muscles and chest muscles help you to breathe. Exhalation usually is a passive maneuver. So I take a breath, I relax, and I exhale because the elasticity of the lungs and the chest push the air out. But if we have to cough, these exhalatory muscles, which are the abdominal muscles and the internal intercostal muscles, are critical. And I'll mention that at the end of the talk, that not only do we need non-invasive ventilation for people with different neuromuscular diseases, but we need cough assistance as well. Now lastly, I consider the upper airway muscles, so the glottic muscles in the throat, to be breathing muscles. And the reason I consider them to be breathing muscles is because they're controlled, neurologically speaking, from the same areas of the brain as the other breathing muscles. And they are critical during sleep. So even though the ear, nose, and throat doctor would say, get out of my territory, actually they are breathing muscles. This is the diaphragm. This is one of the most beautiful muscles that we have. It's two muscles, one on the right, one on the left. It has a dome up there, which is actually connective tissue. And when it contracts, it drops down like a piston. And it enlarges the lungs, and it brings air into the lungs. It's controlled by the phrenic nerve, which is a very long nerve, two of them actually, that come down along the sides of the heart. And that's why I'm always worried when cardiac surgeons are dissecting it off the heart there. The diaphragm contributes about 70% of the biggest breath we can take, which is known as the vital capacity. Now, I'm not sure this is going to work. Yep, I'm sorry. This was a little video of the diaphragm contracting, and you could see the downward piston motion. It was really a kind of a lovely action. There are many, many, many diseases that affect the muscles directly without affecting the nerves. I see many young men with Duchenne muscular dystrophy, which is one of the most common genetic diseases that we see. But there are lots and lots of other ones, including ones that we can cause. So when I treat patients with asthma or emphysema with steroids, I can very easily cause a myopathy if I use a dose that's high or for a prolonged period of time. So if you're a neurologist or a physician kind of looking to diagnose where might one of these diseases be happening, what we do is we look at the history, the physical exam, and the lab, and the neurologists are really the experts in this area. And they're trying to figure out, okay, is the problem up here in the cortex, in the brain stem, down here? Is it in the muscles or the peripheral nerves? And I sort of stay out of that area. I let them do that because from my point of view, I need to think about three things, and I need to think about it at every visit that I see them. Because breathing, out of all the problems that these neurologic diseases can cause, is the most important, I believe. Because if you can't breathe, as my respiratory therapist told me, if you cannot breathe, nothing else matters. Which is correct. So every time I see a patient with neuromuscular disease in my clinic, I look to see if the inspiratory side of things, the diaphragm and the external intercostal muscles, are active. Nocturnal hypoventilation, as I'll describe in a moment, is one of the very first signs of inspiratory muscle failure. I look for expiratory muscle failure, which is really cough problems, and you can very easily measure that in clinic. And we look at upper airway muscle failure. So particularly for patients with ALS, we're very worried about them aspirating. And when you aspirate and you cannot cough well, that leads to pneumonia, which is the most common cause of death for any neuromuscular disease. So when you hear about someone who's died in the hospital who had polio or has ALS, probably 8 out of 10 times it's going to be a respiratory infection and failure. All right. So what do we do in the clinic? And I work with a very wonderful respiratory therapist. His name is Louis Boitano. He came here, I think, 2 years ago and spoke. He helps me out because directly in clinic we measure a number of things. We measure the vital capacity. Biggest breath you can take. Blow it all the way out as far as you can, and we measure the air that comes out. We then compare it to what it should be for your age and gender and size. Sometimes we measure the maximal inspiratory pressure, the maximal force that you can breathe in. So we have a little mouthpiece and we say, breathe in hard. And we measure that pressure. That's called maximal inspiratory pressure. These are more specialized measurements we do not do routinely in clinic. For expiratory function, how much can somebody exhale, we do something called peak cough flow. I really like this. I think it's a very good thing to measure for people with neuromuscular disease, and I'll show you how that's done. We also at least get a history about upper airway function while they're in clinic. We have a good speech and swallowing clinic where I work, and we send them there where they'll sometimes do a barium swallow study to see how swallowing goes, or even look at the vocal cords and upper airway. Now, sleep and neuromuscular disease. These are intertwined as closely as you could possibly be for the following reasons. When there is weakness of the respiratory and chest muscles, it impairs the ability of that pump to work. Oftentimes there's also weakness of upper airway muscles that increases the resistance to airflow during sleep. So if the muscles are weak, they kind of collapse a little bit. During REM, and Dr. Hahn showed this in one of his slides, during REM, which is rapid eye movement or dream sleep, if we didn't have hypotonia or a relaxation of the muscles, we would flail about and we might injure or kill our bed partner, which would not be good for survival of the tribe. And so the system is designed so that we don't move when we're dreaming, so we don't injure ourselves or anyone else. When that atonia happens, the only muscle that's really working to help us breathe is the diaphragm. If the diaphragm is weak, no other muscles are helping, the likelihood of hypoventilation is very, very high. And so we see really dramatic decreases in breathing or minute ventilation and alveolar or actual ventilation during sleep. And it's dramatic, And some of the most dramatic sleep studies that I have seen, and I'm not a sleep doctor, but I see them sometimes, are in people with neuromuscular disease, where the desaturations are enormous. The time when they're not breathing is very extensive. In addition, because respiratory muscles are working hard during the day to keep us going, they can be fatigued, and that may show up during sleep. And kyphoscoliosis, which many people with polio, post-polio syndrome have, can actually cause desaturation at night just in and of itself. There's also higher work of breathing due to that stiffer chest, and some of them actually show hyporesponsive chemoreceptor due to different inputs from the periphery. So that's an area that's not been studied well, but has been hypothesized. So if you look at sleep in neuromuscular disease, and this was from a well-known author in this field, you can find incredible amounts of pathology during sleep for those who have neuromuscular disease, including post-polio. Snoring, the most basic, but obstructive apneas, hypoventilation, smaller breaths, not breathing enough, central apneas where there's actually no breathing efforts at all, what we call pseudo-central apneas, which are probably severe hypoventilations. You get decreased REM sleep because the body kind of protects itself. It doesn't want to go into REM, and sometimes absent REM. The problem there is that REM sleep is what we really need for kind of alertness during the day and a feeling and sense of clarity and energy. Severe desaturation CO2 and REM is particularly affected. And this is from Peter Bai from 1990. Same kind of slide that Dr. Hahn showed. This is transcutaneous CO2 up here. This is the oxygen saturation. That's 60%, 70%. So during REM sleep, whoa, down below 70% in the O2 sat. And simultaneously, the carbon dioxide is going up during REM. So REM is bad, and that's why most patients sort of automatically avoid it. But what can we do? There are things that we can do for this, fortunately. We really want to, with our treatment, improve and stabilize gas exchange during sleep, so keep the oxygen up and the CO2 down, because I think, as we'll hear later, there's some very bad effects of those problems during sleep on the heart. We want to make the patient feel better, right? We want them to be alert during the day, feel wide awake, improve the sleep quality and quality of life, and if we could, extend survival. The most common methods of support in this day and age are really what we call pressure ventilation, usually through a bi-level type device, which are readily available. There are other ways to do things. There's volume ventilation, which is used in Europe. There's something called AVAPs. I would not suggest that. We've been working with that quite a bit and have not found it to be successful at all. I would say bi-level is really the gold standard, and everyone should not only have the bi-level, but what's called a backup rate, so that when they have central apnea and stop breathing, the machine will kick in. Most of it is done via nasal mask, but sometimes there's a mouth leak, so we need a chin strap. If the leak cannot be treated with a chin strap, we go to a full face mask, and ResMed makes a really beautiful full face mask called the Liberty, which is we found very helpful. Here are a number of the different nasal masks. Some of you may be familiar with these. They're now, I don't know, probably 50 or more masks available. And what used to be a very difficult problem of some people who had larger, unusually shaped noses of getting a fit, now that's disappeared. There is a mask for everyone, I would say. Here are full face masks. These must be vented. So we occasionally have people with these masks at home, but they must have a vent so that the carbon dioxide can leave. I would say only about 10% of our patients use a full face mask. It's just not necessary most of the time. Here are the chin straps. And these are some of the devices that are available. The machines have gotten so small, I can't believe it. I mean, you can like fit them in a purse now, a small purse. These are bi-level devices. They're pressure devices. They don't give you a fixed volume. They give you a set pressure. There's what's called the inspiratory positive airway pressure, the expiratory, and then we set a backup rate. Some of the devices allow for what's called a rise time, where you can adjust how quickly the patient gets the air. That can be a major comfort issue. Humidification is important, and that is almost everyone who's on one of these chronically will get a dry nose, mouth. If you do not use humidification, all of the devices now pretty much have that. Well, what about the effectiveness of this? There haven't been a lot of randomized controlled trials, and what that means is where you give one group the device and you withhold the device from another group with the same disease. This has not been done in neuromuscular because most people think it would be unethical to withhold treatment when you're pretty darn sure that it works based on a physiologic basis and from reports in the past, sort of case series. There are many, many case series that show that you can reduce carbon dioxide level, improve oxygen levels, and people will survive a very long time on non-invasive ventilation. But this is one of the only randomized controlled trials. It was done in ALS patients, and what they were looking at was quality of life. They also looked at survival, but what they showed was that the quality of life improved dramatically, and the functional rating scale, which is a number that says how badly are you affected by the ALS, went down, which is good. So they randomized to group 2 and not to non-invasive ventilation. They showed quality of life improved, and in another part of this study, they showed that survival improved. There is absolutely no doubt in my mind that survival for people who have sleep-disordered breathing, hypercarbia, potentially hypoxemia, and have neuromuscular disease is improved with nocturnal, non-invasive ventilation. Okay, I'll skip through that. Actually, we can go ahead. In a study by Melis in the European Respiratory Journal, in a group of mixed neuromuscular diseases, some post-polio, some ALS, some myopathies, they used bi-level type devices. They made adjustments with sleep studies, and what they found was that the mean settings for the machine were an inspiratory pressure of about 14 centimeters of water, expiratory pressure of about 4, and the backup rate was fairly high at around 19. That may have been to do with some of the types of patients that they have. We haven't found that we need that high a backup rate, but it shows you that the pressures that you need are moderately high and can be quite high in some patients. So what I did, and I kind of developed these slides for the sleep doctors at our institution to help them with their titration studies, which means when the patient is wearing the device, you send them for a sleep study and you want to find out what's the best setting for them. The number one thing, do not use CPAP in a neuromuscular patient. I've had many come to my clinic where CPAP is used, and it was because the technicians were looking at the sleep study and they just kept constantly increasing CPAP, and they sent them out on 17 of CPAP. And that will not work, all right? It really needs to be a bi-level device. What we do is we set the EPAP, the expiratory pressure, to relatively low level because obstructive apneas are usually pretty easily treated, and we use the IPAP to treat hypoventilation, and then lastly, the respiratory rate, we dial it up. So this is what we tell the technicians to do. Start the EPAP at 4 to 5, start the IPAP at around 8 centimeters of water, slowly increase it to treat the hypoventilation, and then later bump the respiratory rate up. The mistakes that I see, and I include this in a little packet I send over them, never use CPAP. Sometimes you'll see that the patients will come back to my clinic and they'll have an inspiratory pressure of 18 and an expiratory pressure of 15. That means that the amount of pressure that's giving them a breath is 3 centimeters of water, which is like, the very weak pressure. So it's really not helping them. And again, the technicians have dialed up that CPAP portion of it. So if I see this, I know there's a problem, and I send them back. Oftentimes, people come with no backup rate, and then most neuromuscular diseases tend to get slowly worse over time, and if you do not follow up either with a home oximetry study or a sleep study, you are probably missing worsening of the problem. Now, daytime assistance, we sometimes need, and we do that if the CO2 remains high despite a good nocturnal treatment, recurrent pneumonias, or if there's cough support needed. And for us, we use, for people who are in wheelchairs, we use a mouthpiece ventilator set up to a volume cycled ventilator. This was developed actually during the polio epidemics of the 1950s to allow patients time out of the iron lung for nursing care. But it was kind of popularized by Alba and Bach in the 1980s, and now there are a lot of ventilators that do great things with this. And this is a beautiful device. We use it particularly for our muscular dystrophy patients who are in a wheelchair. And we've had people go for 8, 9, 10 years. I have several Duchenne patients who are now 35 to 40 years old, which is totally unheard of, 20 years ago. So that's a lot of fun. This is one of our patients. That's how they use it. Okay, I've talked about that already. The last slide, cough augmentation. So supporting breathing during sleep and during the day is important, but if you get a cold or a chest infection, cough support is absolutely critical, because if you cannot cough, and maybe this is number 2 for the respiratory therapist, if you can't cough, not a lot else matters, because it will stay in your lungs, you'll get bacterial infection, you will die of pneumonia. So what we do is we use manual augmentation of cough, or quad coughing. We use hyperinflation. The beautiful thing about the lungs and the chest is if you take a big breath, it really wants to recoil inwards. It wants to push air out, because it's like stretching a rubber band, all right, and then letting it snap back. So if we use a little resuscitator bag, we can pump up the person who can't do it on their own. So you need an assistant for that, and that's Louis Boitano there. But there's a wonderful device that was developed by Jack Emerson, who was kind of a pioneer in respiratory therapy. This is called the Cough Assist, or the insufflator, exsufflator. And what it does is it kind of generates a cough. So it gives you a little breath in, like you do when you cough, and then it just vacuums the air out. So it's like a vacuum cleaner for the airways. And this baby is fantastic. All of my patients who have weak cough flow that we measure in the clinic have one of these at home in their closet. And the way we measure peak cough flow is we have a little asthma peak flow meter with a face mask on it, and we say, cough as hard as you can. And the flow coming out of the mouth, usually, like what I just did was probably 500 liters per minute, 600. When that gets down to roughly about 200 liters per minute, right, so about 25 to 30% of what it should be, the likelihood of being unable to get stuff out of the lungs is high, and that's when we have people use that type of machine. Really a good thing, and it used to be we had to write all kinds of letters to the insurers to get these things, and if you don't get it for the patient, they're going to die, and they're much more reasonable in this day and age. Interestingly, in Canada, they don't have these. They can't get them, so they teach people how to do this and do it at home on their own. Yeah, interesting. Okay, so the key summary points, and are we back on time? I think, did I barely do it? Maybe not. All right. So neuromuscular diseases, including post-polio and polio, are diseases that have very complex sleep-disordered breathing. And if that's the one thing you had to take away from this, sleep is key for patients with this. Non-invasive positive pressure ventilation, or bilevel, or sometimes called BiPAP, which is really just a trade name for the machine. VPAP is another machine. Non-invasive ventilation, not CPAP, is required. If your doctor tries to put you on CPAP, I would talk extensively with them about that, or her. Although a sleep study may not be required to actually start the devices, oftentimes going to the sleep lab and adjusting it can be helpful. Backup rates are almost always needed. Neuromuscular diseases are often progressive, so you need careful follow-up. You just don't send somebody home with a device. And then daytime ventilation may be needed for people who are having symptoms or carbon dioxide elevation despite maximal nighttime therapy. Thank you. Any questions? Yes?
What is the difference in the way the CPAP and the BiPAP function?
Sure.
What is the difference?
What is the difference? Thank you for asking that. CPAP is continuous positive airway pressure with a mask on. The machine gives you a continuous kind of column of air and pressure in the airway. It is very appropriate for people who have what's called obstructive sleep apnea, which is kind of the classic middle-aged male like myself who might be overweight, who has a thick neck, this shirt size is going up and up, and snores loudly but then stops snoring. So you give them this continuous column of air that holds their throat open, and that's CPAP. BiPAP is bilevel positive airway pressure. So instead of just one pressure kind of coming at you, it cycles between a higher pressure and then a lower pressure. So it really acts like a true ventilator, like a machine that takes over for the breathing muscles and gives you air, volumes of air based on the pressure. So you might get a higher pressure of 15, air goes in, and then you drop to the lower pressure of 5 and air goes out. So it's a pump, basically. And the reason that neuromuscular people or patients need this is because obstructive apnea can happen in them, but it's only one part of what's going on. The rest is when the muscles are weak, you don't take big enough breaths, you might not take any breaths at all, so you need really extra assistance. The thing is that CPAP is so common, okay, because middle-aged, overweight men with big necks are really common. There are millions of people who are on CPAP, am I right? I would say there are millions. Whereas for our group here, we're a little more specialized, and there might be thousands or maybe 100,000 or more who are needing BiPAP for this kind of issue. So what happens is, forgive me, Dr. Hahn, but the sleep doctors, everything kind of looks a little bit like obstructive apnea, and so people get treated that way, and that's why you see mistakes where they're not saying, this patient has a more complicated situation, and we need to treat with something a little different. Question?
Yes, hi, doctor.
Yes.
Very, very beautiful lecture, by the way.
Sure.
My name is Liz Gertis, and I am sleep apnea diagnosed.
Okay.
I actually stop breathing.
Okay.
And I was just wondering, you didn't go into things to watch out for, like for several years I woke up with a basal brain headache and didn't know what it was. I thought someone was hitting me while I was asleep at night with a board in the back of the head.
Sure.
So you didn't go into
Sure, I didn't. Right.
some of those things, but that is something to watch out for, because I know the post-polio survivors are very hard-nosed, very independent.
Yes.
I'll do it myself, thank you, people. And so to look out for things that pop up.
Sure. No,
Also,
absolutely.
I have developed a rapid heartbeat syndrome that I think is probably associated, if not directly, indirectly, with the sleep apnea. Is that correct? Because you said something about heart affecting
It could
your
be,
heart.
and I think in the afternoon, or we're going to have more on that, but definitely
okay.
arrhythmias can be
Yeah.
seen with
Okay.
hypoventilation sleep apnea.
Okay.
Yes, I'm sorry. Angela asked me to kind of the broad overview, so I was kind of rushing through things. But you're absolutely right. I didn't really talk about, what should the patient be looking for as symptoms of a nocturnal problem. So absolutely, morning headache, consistent, repeated morning headache is a big kind of warning sign. Sleepiness during the day, so, falling asleep, doing normal things, even, God forbid, driving. Depression, hypertension, lack of concentration. And then even things like getting up at night to go to the bathroom, whereas you might do it one time. Once you develop sleep disorder breathing, it might be 3, 4, 5 times a night, and you're not sure why. That's another symptom. There are actually what are called sleepiness scoring systems. The most famous one is called the Epworth, which is kind of a questionnaire as to how sleepy you are. So yes, absolutely. And that morning headache is one that I see frequently in neuromuscular because the CO2 goes up, and that's probably what causes that.
Yes.
Oh, there's stuff on the table about, oh, great. Wonderful. I'm glad. There's handouts about symptoms on the display tables.
Just a very short question. You explained CPAP and BiPAP. Now what about the VPAP? What does it do over and above?
VPAP, so BiPAP, the word BiPAP is actually a trade name for a device and system by Respironics. VPAP is the trade name for ResMed, and I would say the algorithm, the kind of computer and all that is fairly similar. There are a number of bi-level type machines from ResMed, from Respironics, but also from other companies. It probably is better, and I always tell people to kind of call it bi-level support rather than BiPAP, because then it gets into kind of, is it the machine, is it the technique, or what? And what we're, obviously in Europe, there are many different machines. They do just great work over there. So it's more the sort of theory and the type of device, I would say. Question?
Dr. Benditt?
Yes.
I have a cough assist machine.
Mm-hmm.
I don't know why I have it, to be honest with you. But I think to keep the expiratory muscles going strong, which is my problem, it's probably not a bad idea to use. But the thing is I'm not coughing. I don't cough. I don't have problems. I think the problem is probably down in the alveoli. Maybe they're not working correctly. Should I have a test done to see why I'm not excreting phlegm or?
No, that's fantastic. I'm great. No, I'm really happy. And that's good. And it means that I think it means you don't have a problem, that your pulmonary system is healthy. And it's great. Cough we don't really need until we need it, which means a cold, chest cold, pneumonia. And so, for instance, my patients who have this at home, they have it there. They do not use it all the time. They use it when they get into trouble. For certain patients who have really severe disease, I ask them to use it every day to expand the lungs, because there is some data in ALS patients that if you kind of hyperexpand the lungs and the chest, you can increase the flexibility. It's kind of like yoga for the lungs or something, where you kind of stretch it and they do better. There's not a huge amount of data, but it's suggestive and it's very easy to do. So I'll tell my most severe muscular dystrophy patients who might have a vital capacity of like 6% predicted to each day, morning and night, do these expansion exercises to help. You know, I don't know you, but I would say you probably don't need to do that, but it's possible to do. But I would say kind of God bless and keep it, because if you develop a pneumonia, that will be a key instrument, I think.
Okay, last thing here. I'm going through a blood pressure crisis right now. My heart seems to run like crazy at night for some reason, and my morning blood pressure is like 160/100, let's say. Is there some specific kind of blood pressure medication that post-polio people should stay away from, maybe, or like I don't know how to say it, but
angiotensin converting ACE inhibitors?
Yes.
I'm not aware of any that post-polio specifically needs to stay away from. If the blood pressure, is higher in the morning, though, certainly sleep-disordered breathing and sleep apnea can lead to blood pressure elevations. And that might be something worth looking at, and talking with your doctor about. So, yeah.
Last question.
Yeah.
When you were talking about using the when you were talking about using the cough assist, prophylactically to expand, is that the same concept as breath stacking?
Absolutely.
And
yeah. You
would you recommend it for everybody?
Well, the The question was about whether, if you do breath stacking, so you take that little resuscitator bag and you kind of inflate yourself, is it the same as the cough assist where it pushes air in? And absolutely, it's the same idea. And you could do it just with that. You wouldn't have to have a cough assist at home, but it's easy to do with the cough assist, obviously.
Is it something that you recommend everybody do regularly?
I don't it depends on how severe they are. I don't say, I have people who come in who are vital capacity is 50%, they're not having cough problems, they don't have scoliosis. I don't recommend it, but when people start to get lower, we talk to just about everybody about it. So, yeah.
Okay, thank you very much,
Yeah,
Dr.
sure.
Benditt.